So my name's Andrew O'Shaughnessy. I'm a consultant in public health in Bradford, and one of my areas of interest for about 10 or 15 years has been tuberculosis. Obviously, working in Bradford, we get a great deal of tuberculosis. Not quite so much in Barnsley, but that doesn't mean it's not still important. I was asked to come down to Barnsley in the second part of last year to do a review of TB in Barnsley following some issues that you've had here that I think were just alluded to. And I usually take what we call a health needs assessment approach in circumstances like this, and that piece of work was completed just towards the end of last year. We did a lot of stakeholder engagement, speaking with stakeholders, the usual epidemiological analyses, went through the evidence, the guidelines, etc., and made some strategic recommendations for you. For those of you who aren't familiar with the health need assessment approach, just very quickly, incidence and prevalence of disease, review of existing services, analysis of effectiveness and cost effectiveness of interventions, throw them all together and you should come out with an answer of some sort. Just to be very clear, tuberculosis, as you all know, is a communicable disease spread largely by droplet spread. It's fatal if untreated. You don't treat TB, you're going to die. If you have TB and it's untreated, you will on average infect another 10 to 15 people. Obviously, depending where the TB is and what your social family circumstances are, etc. It's probably a lot more, for example, in a prison. Prisons are the perfect breeding ground for tuberculosis, for example. It's always a big problem when we have a case in a prison. The most common presentation for tuberculosis is pulmonary, in the lungs, as I'm sure you all know. But it does occur in other parts of the body, most notably the skeletal system, spinal TB being the most common of those. There's other more complex cases such as GI TB, even cerebral TB. Those are a lot rarer, but most orthopaedic surgeons will see a few cases of skeletal TB in their careers. Important message, 90% of TB is latent. Only 1 in 10 cases are actually active. Most people, a little bit like chicken pox and shingles, will have latent TB sitting around in their body for many, many years until an event or pure chance causes it to activate into active disease. Important things to consider in terms of TB and whether somebody might have TB. And I'll talk a bit more about making that distinction shortly. Ethnicity is very, very important. If somebody comes from an area where TB is endemic, particularly South Asia, for example, you would have a raised index of suspicion. Deprivation, homelessness, and substance abuse. Those three together are like a perfect storm for TB, and again, social circumstances very important. And also, as I'm sure you can imagine, immunocompromise is particularly important. As your immune system is depleted, you're just much more likely you're going to activate any latent infection, and TB in people with HIV is a very serious issue. For you as clinicians, what would you do if you thought you had a case of TB? The standard thing, very simple, sputum and chest x-ray. Send off a sputum sample, they test for acid-fast bacilli, still the same. A chest x-ray will often show lesions and cavitation, which are suggestive of TB. We also have immunoglobulin testing these days at IGRA. We tend to use that more in outbreaks rather than on a routine day-to-day basis. We still treat TB with triple therapy that you'll have learnt about at medical school or elsewhere, rifampicin, isoniazid, etc. And sometimes we have to add in additional drugs. Chemoprophylaxis, for example, with rifampicin, is given to contacts of people with TB on the basis that if they have been infected and are subclinical or preclinical, you can kill off the bug before it forms an active infection. So when somebody has a case of TB, we will send TB nurses out into the community who will then go ask questions of the family and associates and prescribe TB TB prophylaxis as appropriate. Vaccination programs, we do have a very effective vaccination for TB. We don't use it universally. It's only used when the rate of TB incidence exceeds a certain threshold, which Barnsley is not ever going to reach, I do hope. And it's only used in targeted areas such as certain parts of London, for example. We came close to the threshold in Bradford just a few years ago. but we didn't institute because we felt it was just a one-off artefact, which it was, thankfully. Sometimes it's used in a targeted manner, for example, on maternity wards when there's high-risk patients. Directly observed therapy is a very important aspect of TB control because, as I've said, many people who have TB are from more socially chaotic circumstances such as homeless, substance abuse, etc., and they don't necessarily have the discipline to take medicine every day, and so they will go to a pharmacist or one of the nurses will go out into the community, sometimes literally dragging them out of houses to make sure they take their medicine. Because if you don't take the medicine, obviously, and you don't complete your course, not only are you not going to get better, but it's going to lead to potentially drug-resistant strains of TB, which I'll talk about in just a moment. I've spoken about complex cases in the GI, spine, etc. In terms of drug resistance, multi-drug resistant TB is the big worry for us in terms of TB. It's much more difficult to treat, very expensive, and tends to occur in people from more socially chaotic backgrounds, and that actually in itself subsumes huge amounts of other resource other than just financial resource. And I've experience of dealing with these, and I can tell you it takes up a colossal amount of time and effort to manage people. Sometimes you have to use the law to forcibly put people into a hospital room under police guard to keep them away from the general public because we can't have them infecting others with multi-drug resistant TB. Just in terms of the national context, I'll just be very quick. TB is a major concern for us in terms of communicable disease control. Levels have been fairly static since about 2005, but they are at the highest they've been since the 1980s, and higher than most other Western European countries, 5 times higher than the States. In the US, they've got a fantastic program of tailing off TB incidents. They're miles ahead of us, and we really need to be copying them to bring rates down. It tends to be focused on certain areas which are high incidence, generally reflecting the ethnic and migrant demographics of those areas. So, for example, Bradford, which has got a very large South Asian community, mostly concentrated in the city centre, we are one of the hotspots for the TB. We have had notable achievements across the country. A lot of work's been done, but it's still a huge problem. And we've just had a new national strategy published about 3 months ago, which lists 10 key priorities for all areas to follow. So it is very much still a high national concern. As again, costly multi-drug resistant TB is a key concern. TB in children, we always worry a lot about because that's a sentinel sign that your control systems aren't working very well. So it's a concern to us, and we have been talking to the paediatricians here in Barnsley about this. And we do have, in the Public Health Outcomes Framework, a national outcome for TB treatment completion, which is great. In terms of national epidemiology, in 2012, we had just under 9,000 cases of TB. It's about 13.9, 14 per 100,000. Most are people who are born in the high burden countries that I've mentioned, and also people who live in family circumstances with people from, for example, South Asia, the Indian subcontinent. Cases born outside the UK, almost half diagnosed within 5 years of arrival, and this is the latent TB reactivating, which is very interesting. And 7.3% of cases had at least one of those social risk factors that I alluded to before. Only 43% were reported to have started on directly observed therapy, which is a real failing that needs to be approaching 100%. So for Barnsley, Barnsley is a low incidence area in respect of TB. You get an average of about 8 cases a year in Barnsley. Most of them are in British people. Services, though, are reporting, and we have anecdotal reports, that there are rises in the number of people from Central and Eastern Europe who are coming to Barnsley with TB. We've done a lot of work on the Central and Eastern European population in Bradford, because they're quite a new migrant demographic for us, and cultural issues play a large part here, and that we have found that often people from Central and Eastern European don't want to put themselves on registers, for example. We don't know why this might be, perhaps a fear of being sent back to where they've come from. It's purely a cultural issue, and What concerns us is that if somebody gets TB and we don't know who they are, where they are, and how we can get to them, is a major concern. The other major concern is that parts of Central and Eastern Europe, particularly around Latvia, have particular problems with multi-drug resistant TB. And obviously, the worst scenario we could imagine is somebody with multi-drug resistant TB coming to Barnsley, and we can't trace them and actively give them, for example, directly observed therapy. That's a key concern. For your local services, primary care, GPs are generally the first point of call for people with respiratory illness. In terms of TB diagnosis, most of you aren't going to see any cases of TB because it's relatively low incidence in Barnsley, but the symptomatology is, it's not entirely, shall I say, just tick 3 boxes and it's TB. It's people with a chronic cough. They'll often have night sweats, lymphadenopathy, particularly cervical lymphadenopathy. What's most important for you as GPs is to ask the question that allows you to know if that person has been in contact with someone who's likely to have TB. So the first question, have you been in contact with anybody who's had TB? Is always worth asking. You'd be surprised how many will say, yes, I have. Secondly, have they been in contact with somebody who's recently arrived from, say, a long period in Bangladesh or India or Central and Eastern Europe who's been unwell? These are simple questions. The most important question you can ask is that question that would raise your index of suspicion, just as a routine, just to screen out as best you can. In terms of what we do out in the community in Barnsley, there's the Community Health Integration Team, who are largely the nurses who go out and manage TB in the community, because it is a community-based illness. We don't admit people very often for TB, to make sure they're taking their therapy, that they're doing well, and general follow-up. Secondary care at Barnsley Hospitals, it should be an NHS Foundation Trust, some tertiary care in Sheffield, and in terms of the experts you'd be dealing with, obviously respiratory medicine, but then radiology, microbiology and paediatrics are the other important specialisms at the hospital. We did what we call a corporate needs assessment, where we went round and it was a qualitative piece of work using very basic qualitative methodology with all the stakeholders. And the major thing was communication, that people aren't naturally and organically talking to each other about TB across the various sectors in health and social care. The recurrent things that cropped up time and time again was we need a system, that everybody understands what the system is. The importance of a good MDT, particularly in the low incidence area, is very important. The importance of networks, not just professional networks, but networks with your adjoining districts. So if people are moving between districts, you might be able to have links there. A review of the community team processes to make them more effective in engaging with you and secondary care, and the need for regular formal training for people like yourselves, for practice nurses, for secondary care, people in A&E, so they know if somebody comes in who's unwell with a pyrexia, to maybe ask that question. Guidance, there's lots of guidance available to you. We do have a dedicated, nice clinical guideline. There's others on public health guidance from people from hard-to-reach groups with TB, for example. There is also guidance on, for example, TB in people with HIV, which obviously some secondary care physicians would be interested in. Cost of treating the normal case of TB is about £5,000, £50,000 to £70,000 for an MDR TB case, plus the extra costs that I alluded to before, the indirect costs. Late diagnosis, poor management risk, spread, 10 to 15 spreads for each person. One thing I would like to just point out is just the economic circumstances of the individual with TB. Very often they can't then work. They may be particularly unwell. The reason I say that is because there is good evidence out there, particularly for MDR TB patients, that counselling and financial support can actually help to progress a cure. So it's always worth thinking about what are that patient's social circumstances going to be now that they've got TB. The local strategy, which came out in 2013 to 16, which is before the new national strategy, Three key priorities: preventing transmission through early detection and treatment, preventing disease and exposed individuals through identification of contacts to chemoprophylaxis, and immunisation of at-risk individuals with BCG vaccine. I was asked, it's my final slide, I was asked when I finished this piece of work just to come up with 2 scenarios that would satisfy us that we had a decent TB system here in Barnsley. The 2 I came up with, and these ones were TB summits towards the end of the year, was number 1, could we cope rapidly and effectively with an outbreak of TB in a school? Great way to test the system. And the other one I had was a case of MDR-TB in an untraceable migrant worker moving from job to job that we can't keep hold of. Could we rapidly and successfully manage those 2 scenarios? I think if we could, everything would be okay. So, thank you very much for your attention. I'm happy to take your questions.